Okay, good afternoon everyone. Welcome to today's meeting. This is the Adults Health and Active Lifestyle Scrutiny Board. My name is Andrew Scapes. I'm a councillor for the Beeston Holbeck ward and I am the chair of this meeting. Just to let everyone know, this meeting is being recorded and webcast so people can look back or watch it live. You can do that on YouTube or on the council's website. For the benefit of the watching public and everyone in the room, I think we're going to start with some introductions. I'm going to start with just the board and then we'll introduce people who are speaking in items shortly. So as I said, I'm Andrew Scapes. I'm the chair of this meeting. I'm a councillor for Beeston Holbeck and we'll go to my left. Thank you.
Good afternoon folks, I'm Councillor Adrian McCluskey from Farnley and Wortley.
Good afternoon, Councillor Bromley, Horsforth and Rawdon.
Afternoon, Councillor Mohammed Iqbal from Hunslet and Riverside. Forgive me for horsey voice. Thank you.
Good afternoon, I'm Jonathan Phillips. I'm co-chair of Health Watch Leeds and me and my colleague are co-opted onto this panel.
Good afternoon, Councillor Thackeray from Crossgates and Winmore.
Good afternoon, Councillor Lynn Buckley from All Woodley Ward.
Good afternoon, everybody. My name's Sandy. I'm Councillor Sandy Lay for Otley and Yeadon Ward.
Good afternoon, and I'm Angela Brogden, the Principal Scrutiny Advisor to this board.
Super, thank you very much. And we're going to just go through the first few regular items. Over to you, Angela.
Yep, thank you, Chair. So in relation to item 1, just to confirm there are no appeals against the refusal of inspection of documents. In relation to item 2, there are no items for the exclusion of the public. Under item 3, there are no late items. And under item 4, at this point, may I ask if members wish to declare any interests in accordance with the Council's Code of Conduct? And I shall take silence as none, thank you. And in relation to apologies, we have received apologies, Chair, from Councillor Cunningham. Thank you.
Thank you very much, Angela. Okay, so moving on to item 6, which is the minutes of the previous meeting. This is on pages 5 to 12 of your meeting packs. Those watching online, you can put into any search engine the appropriate name of the scrutiny board and it should come up. Are there any comments on accuracy first? I can't see anyone indicating. Are there any matters arising, Angela?
I guess just for members' information, this was mentioned at the June meeting. So in relation to item 11, Leeds Provider Partnership, there is actually a report being considered by the Executive Board at the meeting tomorrow, and that does reflect the comments that were made by this board as well.
Thank you, Angela. Any other matters arising that members want to raise? No? Okay. So we'll take those as accepted and we'll move on to item 7. So this is a report on maternity gynecology care and endometriosis. Just like to say at the start, we welcome volunteers from Endometriosis UK, Leeds and Bradford, and Menstrual Health Support Leeds, and Councillor Thompson, who are all watching in the gallery observing this meeting. Let's start by introducing guests. So if we start with you, Victoria, if that's okay.
Good afternoon, everyone. I'm Victoria Eaton. I'm the Director of Public Health for Leeds.
Afternoon, I'm Emma Flint. I'm the Executive Member for Adults Health and Equality.
Good afternoon, I'm Brendan Brown. I'm the Chief Executive at Leeds Teaching Hospitals.
Good afternoon, I'm Mike Harvey. I'm Director of Transformation at Leeds Teaching Hospitals.
Good afternoon. I'm Elizabeth Garthwaite, Chief Medical Officer at Leeds Teaching Hospitals.
Good afternoon, I'm Beverly Geary, I'm Chief Nurse at Leeds Teaching Hospitals.
Good afternoon, everybody. I'm Caroline Barrier. I'm the Director for Adult Health and Social Care at the Council.
Thank you and welcome to today's meeting. I'm going to hand over to Brendan. You can assume we've read your report, but welcome any opening remarks. Thank you.
Okay, thank you, Chair. Thank you for inviting us back to Scrutiny. This afternoon I'm joined by colleagues with a focus on women's health. I think, as the paper describes, as one of the largest providers for a breadth of women's health services across the north of England, we provide services that include maternity, neonatal, gynecology, gynecological oncology, urogynecology and reproductive medicine services, as well as specialist endometriosis services. I think Councillor Scopes, you'd written to me back in January and I'd responded specifically about some of the concerns that had rightly been raised by people using our services around endometriosis care. And I gave you an assurance about how things would be improving. We're going to talk to you today about the challenges we've seen in improving aspects of our care, not solely due, but not solely due to some of the growth that we've seen in people requiring access to our services. So thank you. As I've said, I will hand over to my colleague. Mike's going to talk to you about gynecological services. Elizabeth's going to talk to you about endometriosis, and then I'll follow on with an update on where we are against perinatal care in Leeds teaching hospitals and some of the national reviews that have taken place since we last came to Scrutiny meeting. Over to you, Mike.
Thanks, Brendan. So I thought it might be helpful for councillors and for the committee to get an understanding of where we are as an organisation in terms of our performance and where we sit organisationally in terms of comparative performance. And then I'll go a little bit more into gynecology specifically. So LTHT has continued to experience sustained pressure driven by high demand across our services, as well as delivering on the finance, workforce and demand and capacity challenges. Performance does actually overall remain resilient. However, there remains a number of issues which continue to impact our ability to improve delivery and flow. Our bed occupancy, which is how many patients at any one point in time are in our beds, runs at about 97% consistently, which doesn't take into account the patients that are waiting in the emergency department and other assessment areas to come into hospital. National guidance would say that that should be at about 92% for us to be able to run productively and efficiently. So you can see immediately that pressure starts to build within the organisation. However, in saying that, we still continue to do comparatively well, although we're not where we want to be ultimately in terms of our delivery for patients and their families. Just to give you a bit of a flavour and a snapshot, our emergency care standard, we are currently at around 77% for that. Our target by the end of March next year is 82%. Constitutional standard is 93% for that. So we're still a little bit away from where we want to be ultimately with that, but we have seen sustained incremental improvement in that metric over the last year or so. Referral to treatment, so this is the waiting times and how many patients we treat within 18 weeks of receiving their referral for treatment. So the constitutional standard is again that we should have 85% of those 92% of those patients treated within 18 weeks. We're currently at 69% or thereabouts. Again, we've got a stretch target to hit by the end of March next year of 73.3%. And again, that is a situation that's improving, and we sit 35th out of 134 organisations for that, number one being the best that there is. Our challenges around our longest waiting patients, so we've systematically tried to eat into that long waiting list situation that we've had that built up during COVID but has started to come down. Our current position for people who've waited longer than 52 weeks is 1,405, and that is an improving picture. At the worst of that, it was up at 3,000, so we are incrementally getting better again, and we have a target to hit of 780 or thereabouts by end of March next year. Our total waiting list, so the number of patients who sit on all of our waiting lists, again, has rose during COVID, as it did with every hospital, up to the point where it was over 92,000 patients waiting waiting for any form of treatment, and that could be their first clinic appointment or could be treatment. That's now down at 86,000. Pre-COVID, it was at around 60,000, which is considered a sustainable waiting list. And again, comparatively speaking, compared to some other organisations' equivalents, like Manchester and Birmingham, we are doing comparatively much better than they are. And then on to a couple of cancer metrics specifically. So people might be familiar with the 62-day target, which is to treat patients who are referred on a cancer 2-week wait pathway to treat them within 62 days of their first appointment at the GP, their first referral in from the GP, sorry. We're currently at about 68% for that. We should be at, ideally, the standard should be 85%, but we are improving incrementally from a position where at its lowest it was in the low 50s. And again, comparatively speaking, we're doing relatively well. We do see the most complex patients in Leeds, and we take a significant number of referrals from other organisations in as well, which kind of complicates that, that metric, but it is something that we are improving on and working towards improving longer term. Just on to gynaecology in particular, because I think there'd been a question at the last scrutiny board about understanding the referral growth that has come in. So I think our analysis is suggesting that we've seen something around 78% increase in the number of the demand for general gynaecology services if you go from July last year to July this year, which means effectively we've gone from an average of about 130 patients a month being referred up to about 220 patients a month, something along those lines. There's a number of reasons why that has happened, including growing numbers of women obviously seeking care for chronic gynecological conditions, the ongoing impact of activity backlogs that emerged during COVID, and that's still having some impact, greater awareness amongst patients and GPs of conditions such as menstrual disorders and pelvic floor dysfunction, and the fact that there are some treatments available to them now. Increasing pressure within primary care may be leading to some activity being transferred into secondary care. And then obviously the demographic changes that we're all aware of in the city of an ageing population and clinical complexity, all contributing to that growth. So what are we doing about it? So the service is aware of this and has seen this impact. And there's a number of initiatives that we are working on to try and improve the situation. Some of them are things that we're doing across all services within the hospital, and some of them are very specific to the gynaecology service. So as part of one of the first things is as part of our outpatient transformation programme, we're developing a programme called the Patient Initiated Follow-Up, which essentially looks at patients who might not need to come in for a traditional follow-up appointment but are able to access our care if and when they need it under certain criteria and if they meet certain thresholds, and we give patients the information that they could to work that through so that we can discharge them off our books but they are able to access the service. There is a suggestion when we've looked at our patients who are on our follow-up waiting list that up to 25% of patients across all of our services could be managed under that pathway. It's something patients seem to like, providing that we can guarantee that they can get access back in quickly enough. The next one on from there is expanding our virtual outpatient follow-up models where clinically appropriate, and this builds on successful implementation that we've had within fertility services and paediatric and adolescent gynaecology. So that would be around using virtual technology for patients to be able to access their clinical expert without the need to have to come into hospital. It's usually more effective for patients. Patients seem to like it, and it certainly gives us more capacity to be able to see more patients through that methodology as well. We're going on to address resident doctor workforce gaps to enable reinstatement of clinical capacity, which have been affected by staffing shortages. We're exploring alternative workforce models which don't rely purely on consultant-led clinics. So we're looking at different types of clinicians running services that traditionally would have been provided by consultants, which gives us a greater breadth of people to be able to pull on, to be able to deliver the service. We are using some insourcing arrangements to provide additional outpatient and theatre capacity. We've got a strengthened operational team looking at the oversight of the referral pathway, making sure that patients are progressing through the pathway as they should do, and having a clear understanding of when patients hit certain thresholds, what we need to be doing. And then we're undertaking a comprehensive job planning exercise to align our workforce resources with service and demand for the longer term, so that we don't just get ourselves back into this situation in the future. If I can pass on to Liz now. Liz is going to take us through some of the key work in the endometriosis service. Thank you.
Thank you, Mike. So we know that endometriosis is a nationally recognised condition, and one of the conditions where we know that women experience unacceptable delays, both in diagnosis and in treatment, and improving access to that is an absolute priority. In LTHT, we provide endometriosis services to the local population, but we also provide complex and treatment for very severe endometriosis, and we're recognised for that. We're recognised for it, but we're not commissioned to do that, which means that we continue to have significant challenges around the delivery of that. Our demand has grown really sharply, and you'll see that from the graph in the paper. Referrals have increased by 64% between the year 2023 to 24 and 24-25, with 369 patient episodes in 25-26 to date. So we currently have a large waiting list of 649 patients on the standard waiting list, with 118 on that complex pathway. And we know that waits for outpatient appointments, for the first outpatient appointments, are long, averaging between 48 and 50 weeks. And for the specialist surgery, waits can reach up to 61 weeks. We are working incredibly hard to try and mitigate that and improve access to our patients by increasing the consultant capacity where we can, ensuring that we utilise our theatres in the very best and most effective way so that those patients requiring surgery can access it, and also using in-sourced capacity to try and free up that time. We're also working really closely with NHS England regarding the commissioning of the services, because, as I referred to in my opening statement, that commissioning of those complex services currently isn't in place, and therefore our ability to respond to the increasing demand is challenged in terms of that workforce. We are the only service in West Yorkshire where we provide non-surgical treatment for endometriosis, and we also provide the only thoracic surgery for thoracic endometriosis. So maximising our capacity in those areas, expanding our robotic surgery, and also exploring the non-surgical options is particularly important and something that we're driving towards. The core issue that we have is that we are delivering activity and complexity consistent with a very specialist commissioned centre, but with a funding framework that doesn't align with that designation. And so that commissioning and capacity expansion paper has gone to NHS England, and we're working very hard with them to come to an outcome where our preferred outcome is a formal recommissioning with that recurrent investment. But whilst that's happening, we are working with our partners, with our patients, to ensure access that is prioritised for those patients who need it most, recognising the position that we're in at the moment.
Okay, thank you. Before we open this up to questions, I just thought it would be helpful to update you on where we are against the perinatal independent review that's taken place. As you know, Donna Ockenden was announced as the chair of the independent review into care at Leeds Teaching Hospitals. That will go back over a 15-year period. That review has formally started. It started in April of this year, and that's been much more of a desktop review to this point, gathering evidence and papers. But some of you may be aware that actually Donna Ockenden and her team were in Leeds at the weekend and held it's a town hall event, which is basically an open invite to families who may want to be involved, who may have been harmed or affected by care in Leeds over the last 15 years. So that happened on Saturday of this weekend. The terms of reference for the independent review aren't yet complete. As I said, that's because Donna Ockenden is meeting with families, but we expect to hear about those terms of reference imminently. You'll also be aware that there have been several national reports into maternity care released since certainly I and the team were here last. And that speaks to Ockendon's report into care at Nottingham, the Baroness Amos review into 15 trusts across the country, and then NHSE's 10-point improvement plan. So there are a number of national initiatives taking place across maternity and neonatal care. But what I would say to you is we've built upon the work that I shared with you when we last met, the plans that we've put in place to improve our services in response to the enforcement notices and CQC findings from last year, from 2025. But this speaks to, this isn't just about action plans or ticking boxes or amber, green or red ratings. This is about the care that we offer to our communities and how we communicate with them. So work is ongoing. There's an extensive improvement programme happening across our maternity services. And again, I think I was asked last time about, well, what about the proposed new hospital for Leeds teaching hospitals and whether that would happen. And as you know, we are still on the new hospital programme, but it is some years away. But I think that speaks to how do we have a conversation about reconfiguring our services and considering whether we need services on one site or whether we continue with them on both sites for maternity and neonatal services, and actually what's the safest option for our patients, for our communities and for our colleagues. So that really is a whistle-stop tour. I'm sorry if we've gone longer, Chair, but it was to give a flavour of some of the work that's taken place behind the scenes. We can't always capture this in a paper, but there has been a lot happening since we last met. Probably best if we open this up now and take for questions.
Thank you very much, Brendan. I appreciate the information. I thought that was helpful. I'm going to open up to questions, and so if you indicate in a normal way, and I'll make a note. But I'll just start with a couple of questions. On firstly, on endometriosis, I've read recently there's new tests that are being trialled, and I want to know if that was something that was going to happen here in Leeds as well. And then the other thing I'd like to ask about is how much a whole team is being engaged on the improvement plan and journey. So I think if we think about the maternity challenges, one of the things you reflected on, Brendan, was not listening to people the whole way through the organisation. So just want to check in on how much have they, like, you know, the doctors in that team been consulted on the plan, and members, if you indicate.
So if Elizabeth takes the first question and I'll cover the second one, is that okay?
Thank you. So in relation to the first question regarding new technologies and new testing, so our clinical lead for gynaecology is Mr James Tibbett, and we were delighted to welcome councillor colleagues from Leeds Council and Alan Shelbrook to visit theatres with James when he talked to them about the new technologies that we were using. Alongside that, the developments in terms of testing are very much being reviewed, and our approach to that will be that we want to be on the front foot in terms of the development of those robust systems. Again, that comes to the issue of the commissioning of the very specialist services and how we can match the delivery opportunities that we have with the demand and ensure that we are appropriately resourced to deliver to the standards that we absolutely want to do. We have a very innovative team who are very much outward facing and are actually involved in the development of those new strategies. So yes, they are absolutely aligned. Have we got the ability to do that at the moment? No. But are we delivering high quality, complex, up-to-date care to our patients when we can? Yes. Okay.
And I think in response to your second question, is everybody involved? Yes, they are. But I think in light of the review into care at Nottingham and the Baroness Amos review, what we did was test ourselves. It isn't just about maternity or neonatal services. What we asked ourselves and our senior leadership team, what could be true for us in any service. So whilst these events took place in maternity and neonatal care, our question to ourselves was, could this be happening anywhere else? And that's the tack we've continually taken. And I think a lot of it speaks to your point. How are we truly communicating with, not to, patients? And how are we communicating on our patients' terms, not ours actually. So that's the cultural shift that we're taking forward. I do feel confident that our senior leadership team are taking this seriously and want to be continually involved in the improvement that needs to take place. The improvement that needs to take place isn't just because of a national review, it's because it's the right thing to do. And I think it speaks to how do we provide modern healthcare for the future, but it has to be based on what do our communities need and how do we truly listen to them.
Yeah, thanks, Brendan. I think my question was about, are we doing what you're doing in maternity in endometriosis? And I think you're saying you're doing your best to do that. I'm going to bring Jonathan in next.
Thank you, Chair. Thanks for your papers and the presentations. In the presentations and what you've said, you focus very much on what's an awful lot of work that's going in terms of various kind of meetings and looking at metrics and stuff and managing workflow and pressures. But what I'd like to know more about is what about both the experience and the outcomes for the women who are going through this process, because you haven't really touched on that much. And what I'd like to know is it improving? How do you know it's improving? And where is that evidence coming from?
Thank you. I'm going to hand over to Elizabeth and Beverly to answer that, but I think that probably your question speaks to this isn't just about action plans for us. It is about the experience of the women and their families who are using our services. So we are heavily regulated, and that generates a kind of culture that speaks to action plans, but we're much more interested in what you've just asked me. What is the experience of the people who are using our services, and how do we assure ourselves that their experience is improving? So I know I could hear. I'm going to hand over to Elizabeth and Beverly, who are going to answer that in more detail.
Thank you. So first of all, in response to patient outcomes, we measure the quality of our services using various metrics, and we have really clear governance structures where we report outcomes, but also so we report positive outcomes, but we also investigate when things have gone wrong, so we can be assured that we're not just looking at the good, but looking when things could be improved. We know that our patients accessing the endometriosis service, for example, we have exceptional feedback which we've received from our patients, but we also know that the outcomes of the interventions from our clinical teams are giving the results that that our patients want and require. I think the challenge is those patients who haven't had access to those services yet and are waiting, and what's their experience and how do we support that. So we are doing work in terms of referral triage, our engagement with patients, our engagement with our other stakeholders in terms of primary care. But in terms of the quality of care and the outcomes that we're delivering both in gynecology and in endometriosis, I think we're very clear of those outcomes. With regards to maternity and perinatal work, our improvement programmes particularly look at how do we know that the services that we're delivering and the patients that women and families are receiving meet the standards that are required. And that's a proactive process as well as looking back, but looking forward in terms of how we're measuring, how we're responding, and how do we know that people are getting what they need from us. And we've got multiple areas where we deal with that. And I'll hand over to Beverly, who'll talk more about that now.
So in terms of patient experience, particularly for maternity and neonatals, we have the Maternity and Neonatal Voices Partnership. So this is a group of people that we work with that are independent of our service, commissioned by the integrated care boards. And they work with our communities and with families on experience of care. We've got lots of metrics as you've already highlighted, and we're not focused on numbers of complaints and numbers of compliments. We're focused upon the experience of care that our families on a day-to-day basis and how we can improve that. And what we are aspiring to do is include them even more. Some of the things that we've done, and our Maternity Voices Partnership lead within the organisation presents to various forums, and eventually it goes to our board of directors. But we also are, I want to say subject to, we're also invited to monthly meetings with our regulators, CQC, NHSE, and also patient partners to present this information, working with them to look at how we can firm it up, provide them with more assurance. But the most important thing is the feedback from the families. I think that given the size and complexity of our organisation, and that we are subject to an independent review, and that will start when people are coming in, and when they, following the meeting at the weekend with women and families. I think that we could do with additional resource for that. We've already discussed it at our Quality Assurance Committee. There'll be a discussion at our board, and we will be taking that to our Integrated Care Board regarding commissioning of that service. But we've got some brilliant partners that we do work with who are independent, as I've said, and they work with the women in communities. And some of the things that we've done, I've written down baby raves. So they're working in some of our really deprived communities to work with women, and they work with our services, so matrons and midwives within our maternity services to work with women and families to improve things.
Thank you for that. With particular reference to women and families from Black and South Asian groups, could you say a bit more about how you're particularly engaging with them? And also, could you give some actual examples of where experience and outcomes are improving or not improving? So, what's actually the work that you're doing, what's actually coming out of that is actually better than it was a year ago, or not better and you want to make it better? That's what I think we're really interested in.
So with our Maternity Voices Partnership team, we engage with a group of women from the South Asian network. And we had a group of women that came around our services within the hospitals to look at signposting, to look at the murals on the ward, to look at information in various languages. And I think we reported this to board a couple of months ago, actually, because it was such a brilliant piece of work. So it was led by the women within the Black Asian minority group, in conjunction with our staff and with our Maternity Voices Partnership, and the signposting and the information for these families. The feedback is really positive in terms of, it's really clear. There's lots of different languages that can now access the information, and where and signposting in terms of support both in and outside of the hospital is incredibly positive. I don't know if you want to add anything, Liz.
Thank you very much. Yeah. So in terms of what have we actually done and where have we seen improvement? So earlier, it was last month, we did an improvement project on the induction of labour pathways. So that's ladies who are coming into hospital for a planned induction and managing those delays. So we know that ladies will come in and wait a significant amount of time for the pathway to start because of the requirements for observation, access to delivery suite. And an improvement pathway has been put in place to really reduce those delays, and we already have seen a tangible change in the wait that people and the experience of our patients and families. We've also done significant work in our antenatal clinic in terms of the information that we're giving to women and families about their journey through pregnancy, delivery and thereafter, which we've received positive feedback for. In terms of gynecology and endometriosis, given what I said about the extent of the waiting list, it's really difficult to see how that. So for individuals, we're seeing improvements in their journey, but for the people on the waiting list, that's really difficult to manage, and we know that the experiences of those individuals is really challenging. But we've put in place specific interventions with those waiting lists to ensure that we are proactively communicating. So whilst we know that people are waiting, we also know that they know that we are aware that they're waiting, and they're not just in a system where they have no idea what's happening. Now, clearly, information to say that you're on a waiting list doesn't improve your access to services, but we hope that it will allow people to at least recognise that we recognise that they're there, and it gives us an opportunity to re-triage and also signpost to additional services if that's required. Mike mentioned our patient-initiated follow-ups, and that again, not only does that improve and free up capacity in our outpatient services, but it also improves the experience of patients and families not coming to outpatient clinics if it's not required, not taking time off work, not travelling, if they are coming merely to be told that everything's fine and you can be discharged, but ensuring that that's an engagement process rather than a done-to process, so that people are able to access services if required, but aren't unnecessarily making journeys through to our services, which are often central and often quite away from home.
Thank you. I'm just going to, because we're talking about patient experience, so one of our councillor colleagues wrote to me because she'd seen this item on the agenda, and she was recently referred, well, not that recently, 5 months ago, referred by a GP to gynaecology for 2 issues, and it just speaks to some of the things you were saying, Liz. So she says, the referral was acknowledged quickly, but I was told by text message that it could be 52-week wait due to demand. I have since been asked by text and the NHS app, has the problem gone away? Would I be willing to travel up to 100 miles or between 100 and 500 miles to access treatment? But she hasn't had an appointment to date. And I guess you wouldn't expect her to have an appointment to date because she was told 52 waiting list and we're 5 months ago. But I guess there's something there that speaks to communication and how we communicate in a way that is patient-centric, which is, I think, the point Jonathan was making, and helping people who are waiting feel like they're valued, which I think, I just wonder if you have any comments on that, but I think the coldness is something that came through this email that I've had from my councillor colleague. Thank you.
Thank you, and I'm first of all so sorry to hear of this experience and the wait, which we know is too long. We know it's too long, and just to say we're doing everything we can in our capacity to enhance that availability and improve the access. I think the points are really well made, and our ability to communicate is varied and multifold, but sometimes it will appear cold, and it's really important feedback. And what I would have hoped that in that text message would be an option to contact us if required. But we need to ensure that's happening, because, as you say, the experience of the individuals can be really tricky when you are waiting and suffering at the other end. So ensuring that we're not just communicating, but we're also signposting and doing that with the appropriate compassion so that individuals know that they are recognised, and, as you say, not just numbers and not just subject to an arbitrarily very small worded text message. So I'm really grateful for that feedback, and we will take that back.
Thank you, Liz. Okay, I'm going to bring in Councillor Buckley next.
Thank you. You're talking about here about the waiting list for specialist surgery of 61 weeks before they are seen. Is there a particular shortage of consultants to deal with the more specialist surgery? And the other thing is, when I'm looking on this, you said about one of the points raised is reviewing theatre utilisation. Are they being used to the full capacity? Because you're saying, is it lower? It's lower than it used to be, and what's the reason for this?
So I think we're going to take this between us. We might we'll answer each of your questions if that's okay. Yes, there is a shortage, and Liz will go into some of the detail behind that, and then Mike's going to pick up the detail around how we use our theatres.
Thank you. So, as you quite rightly allude to, specialist gynaecological surgery is specialised, and there are a limited number of individuals who are trained with the level of competence that's required. We're very lucky in that whilst our service is small, and small for the size of the population we serve, the expertise and quality of the surgeons that we have is very high. The challenge we face is that we are not funded to employ more specialist surgeons to deliver the very specialist services that we are doing. And therefore, so is the pipeline of supply of specialist surgeons a limiting factor? Partially, but our other limitation is our ability to employ more people to do the very specialist service nature, because it's not what we're commissioned to do, and that's commissioned in other centres. I'll hand over to Mike now to talk about that, the theatre utilisation.
Thanks, Liz. Yeah, so, I mean, people will understand that theatres is some of the most expensive resource that we have within the organisation. We have something around, I can't exactly remember the figure, but it'll be somewhere around mid-60s number of operating theatres within the organisation, and we endeavour to run those at least 2 sessions every day, 5 days a week, and often we work into the weekends, and we work obviously with our acute and our emergency theatres. We operate through the night with those, and we have anything up to 10, 15 of those theatres operating and available all hours 24/7. The challenge, you're absolutely right, Councillor, around our ability to use those resources as much as we are able to. And we've got significant sort of theatre improvement programmes going on across the board. This week we're running an improvement project at Chapel Allerton around the use of the theatres at Chapel Allerton, because that is a site that we should be able to maximise the opportunities to operate on patients up there. The same with Wharfdale, because they're less impacted by the emergency pressures that we see coming through A&E at the LGI and St James's. So there's lots of work goes on with the surgical teams, with the nursing teams, with the theatre teams to try and improve that. It is multifaceted. You know, there's often a significant number of reasons why we don't get to the numbers of the amount of utilisation that we would like. But if you split it down by specialty, we know that some services are much better at this than others. So getting a clearer understanding of why those are better. Sometimes it's to do with the complexity of the patients that they operate on. So in a service where the patients are very complex, getting a fast turnover of patients is more challenging than perhaps up at Chapel Allerton, where it's routine hip and knee surgery, where patients are hopefully more predictable. But there is significant work going on across all of our theatres to try and improve the number and volume of patients that we're getting through the service.
Thank you. Councillor Flint, did you want to come in?
I'm not sure I'm allowed to ask questions. I just wanted to make a few comments, if that's all right. I think this is really important that we're talking about it, and I think we probably all know, like, of someone, like a relative or friend who's on that waiting list. And, you know, these are women, girls who this is really crippling, like, while you're waiting. And I think as women and girls are not educated well about their bodies and about what's happening to your body, I think that, like, the education side of it is obviously not for today, but I feel like that's really important. And the language, you know, kind of around what's happening is really complicated. So there's kind of an inequality already there in, like, who can understand what's happening to their body and also who can advocate for themselves. And I think by the time a woman or girl, like, comes to be referred to your service, you've had to go through so much already to get there. And I just want a kind of assurance that that understanding is there. Like, you know, it's a massive thing to sort of create the time to make the appointment. It's a massive thing to then have to explain, like, an often really emotional and traumatic thing to a GP. Again, there's, like, an inequality of understanding around GPs. You might get someone who's really understanding, you might not. It depends who you get. Very often, these women on the waiting list will have been told just to deal with the pain, and maybe you've got a low pain threshold, like, get better painkillers. So I think there's just lots of barriers to this, and, like, it, you know, it's unacceptable really that we have then, like, a year-long wait for something that you've probably been dealing with for a long time already. And they're the women and girls who've had to fight to get on that waiting list in the first place. So, you know, I just wonder what you think about the kind of women and girls that we're missing on there, and, like, all the kind of inequalities across the city. And I wondered what the conversations are around like the move to neighbourhood health and how important this is, because, you know, we need to understand women's lives, and it's really difficult if you've got a job, 2 jobs, you know, caring responsibilities to get. So we need to bring these services nearer to where women can manage. But it's the waiting list is not acceptable. Funding into, you know, women's services is not acceptable, and I think that just needs to be said out loud. But we're still missing a lot of women, so I think that waiting list is sort of the tip of the iceberg in a way.
So if I can, I think that speaks to what I was describing. That's exactly where we are. We will be driven to deliver an action plan, but behind every point on that action plan is a woman or a young girl who is suffering. I think Victoria and I were part of a Leeds leadership group who met with a group of local school girls who'd won a national award around the impact of period poverty and actually just living with periods, because, as you said, of the lack of education, the medicalisation of it, and just how we're still treating women in 2026. So I think what you've just described speaks to what can we do within our services to improve. And I think absolutely we're committed to how do we deliver a service within a neighbourhood locality that isn't just about moving our services out so it's nearer. It isn't just about delivering an outpatient clinic. It is about education and looking at how we enable women and anybody using our services to live well. What we're not privy to, and I think this might speak in some part to the text example, we're not always privy to the conversation that will have happened before we see those patients. But we need to pay attention to that. We need to look at the totality of a woman's experience and what could have happened to them before they reached our services. I think it speaks to the wider leadership piece about who are we missing, who's living with the consequences of ill health for longer. And I think that speaks to, as you described, how the neighbourhood model is certainly the way forward in improving some of those inequalities and that lack of health equality that we've had for a number of years. I do think we've got the right people leading that at a system level, and there's commitment within the organisation, but I think what you've just described speaks to the continual work that we've got to take forward.
Thanks for that non-question and that answer. Appreciate it. Okay, I'm going to bring in Councillor McCluskey next.
Thank you, Chair. Actually, a number of my questions have been asked. I was going to raise about reviewing theatre utilisation. And in terms of, whilst you've answered most of what I was going to ask, is there a risk, though, down the line that we prioritise one need over another need, and then that becomes a missed opportunity or a missed group of people?
Absolutely. I mean, that's the balance that we have to strike all of the time with all of our services. Is we do dynamically manage our waiting list, our theatre allocation to some extent in response to where we see growth in certain waiting lists over others, and we have those conversations between specialties to say, can we reallocate some of your theatre sessions somewhere else? You can imagine that's not always the most popular conversation that you can have, but it absolutely speaks to the notion that these are our most expensive resources in the hospital, bar intensive care, essentially. So we need to use them in the best way that we can. So hopefully that gives you the assurance that is something that we actively manage on a month-to-month basis. We're just doing some work at the moment around a process called 642, which is about giving sufficient notice to be able to reallocate theatre space when we know that a surgeon isn't available to do a list because they're on holiday or they've got some other commitment. That isn't something that we've been particularly good at in the past, but we are developing this process further now so that from a month out from when we know an operating list should happen, if we haven't got a surgeon allocated from one specialty, we will move another surgeon into that space. Hopefully that will increase the utilisation going forward as well.
Thank you. I did want to ask about, because I mean, obviously the commissioning aspect is a big issue as a specialist service, and you talk about a paper going to NHS England. Have we got a time scale? Have we got do you know when you get an answer?
I think no, not yet. But actually, what I would say is the monthly accountability meeting that we're in gives us an opportunity to raise that directly with specialist commissioning services and NHSE directly. And I think to the wider point, what we can talk about is our patients' experience within that conversation, rather than it just being about pounds, pence and activity figures. So actually, I'm conscious this will be watched, but I see that as a mutual accountability meeting where we can have that conversation and actually push this forward. But we haven't got a date yet.
Thank you. And my final query, I think Councillor Scopes covered it really well though as well, is we've got women and girls on a waiting list 40, 50 weeks. What communication? How could we reassure people that they still count? That they're still, they are going to be seen?
Liz is going to answer this. What I would say is there is a national initiative that has been led by NHSE on how do we, it's not about communicating to, it's communicating with patients who are on a waiting list. I think Liz is going to come into more detail of this though. That needs to mean something for the communities we're serving in Leeds, not just an infographic that we can share with people or, for instance, the text message example. I think it's got to mean something to people. So Liz is going to talk to you in more detail.
Thank you, and I'm so grateful for Councillor Flint's comments because it describes so clearly the challenges that we face. For those individuals who are able to articulate, to speak up and contact us, we have less concern in a way than those individuals who we are totally missing and who have made such an effort to eventually access services and be referred and then are quiet in the background and could so easily be missed. And we're working so hard to address that issue. But this is where our partnership working and where our interactions with all the stakeholders is so important, because for this particular service where we know waits are long, and of course there are other services as well that our patients need to access, it's so important that their expectations are managed, but also that they know how to reach out and communicate and alert us if things aren't right. Because as one of the councillors mentioned, a text being received to say, do you still need to come, is important, because sometimes people choose other avenues or conditions get better, and we can take somebody off a waiting list to enable somebody else to be served. But similarly, people's condition can change from referral, and how do we assure that people aren't deteriorating in silence or not in silence? So that active communication with primary care, with our neighbourhood colleagues who we are working so closely with, not just in a tokenistic way, but in meaningful partnership, to ensure that we have as broad an understanding as possible of those patients who are waiting to be seen. As we've inferred, we have many different ways of communicating. Technology is an advantage, but can be a disadvantage as well for all the reasons that we've already described. But one of the strategies that we have as an organisation is how do we ensure our communication is effective, two-way, and is actually meaningful and engaging, rather than just being a spoken to and an alert, which can sometimes be helpful but really can totally miss the point. So I absolutely take on board what you say, and we recognise the challenge, which is part of our work at all times. And I think as well as dealing with numbers on waiting lists, dealing with time, it's also how are we ensuring that the experience of the patients who we serve and the populations and their families is as acceptable as it can be and is as positive as it can be in the context of not having an infinite resource to be able to manage everybody in the way that we would want to do and in the timeliness that we would really aspire to.
Thank you for that. Okay, Councillor Iqbal next.
Thank you, Chair. Some of the points have been answered, and I just wanted to make a comment that, yes, you're right, it's a huge challenge for the department to deal with women's health issues, and Councillor Flint rightly said that the list is ever so growing because so many people, so many women are not aware or not being able to contact the department. But I can just give you my experience of knowing patients. I know somebody who had very enlarged fibroid and had to wait for a year, and that's, and she went through considerable distress waiting a year for the removal of fibroid. But again, no other health service can compete with our NHS after the operation. you know, the success was brilliant and very happy, but it was a long, long wait. And then there's another experience of somebody I know had some medicine given by a gynae which had serious side effects, but she couldn't get in touch with the department, and just to have a conversation with the gynae, she's on waiting list for a month, and which is quite a long time for a serious issue, where she went to her own GP and they said, well, we can't help you because we're not specialists. So in those kind of, it was one of those areas where should she go to A&E or should she wait for a specialist? And it was difficult, but you know, waiting for a month again for serious issues is a long time. I know it's a huge challenge, but I thought I'll bring this to your attention. Thank you.
I'm really sorry to those two ladies. I think, as you described, waiting a year in pain is an awful experience for somebody, but it's also about what's happening in that year and the impact on their life. I think to the second lady that you talked about, this is part of our challenge and something that we are looking at collectively in Leeds. It's not a straightforward pathway to get advice, and it could and should be better. And I think the neighbourhood approach to healthcare can help with that, but I still think it could and should be better, and we should reduce the bureaucracy so that people can get in touch with the right people at the right time, so that they can get the right advice. So I am dreadfully sorry to the ladies who shared that with you. It could and should be better.
Thank you for that, Brendan. Okay, I'm going to bring in Councillor Bromley next.
Thank you, and thank you for everything discussed so far. I just I sort of wanted to highlight really that there is a layer of success in this, because the amount of referrals means that there is awareness going on, and that's a lot of credit as well, not just in the responses from the NHS and then the training at GP level, but also the fact that there are women that have shared their stories, that has gone national and that has spread, and this is why we're in the situation we're in, which is a layer of success. It's just not easy to handle, and this is the point that we're at. But I just wanted to point that out, because it's so easy to feel overwhelmed all the time, isn't it, with everything not seemingly working. There's 2 points that I wanted to touch on. Firstly, regarding the referrals and the text message and the communication, we do understand on like sort of a business corporate level of how to do that behavioural psychology, and I just wondered if we're managing to feed that in with like wording, so like the waiting maybe being more like counting down, so that people feel that they're in a sense of control and navigation with that. I think you sort of have already touched on it. I just wondered if we could clarify on it a little bit more. And then also with an awareness around then that long waiting time is then potentially really chronic pain and pain management, and then sort of leading to painkillers. And do we have an awareness of how people might be treating themselves in the interim? And then is that something that on a local level really we then need to check in more with people in those scenarios?
I think to your first, so thank you firstly to your first point, that is appreciated. So I think we need to be careful we don't hit the target and miss the point with this, because your point about the app is, I think, to enable access to healthcare digitally, it is a real way forward, and we wouldn't want to be left behind internationally in how we do that. But that speaks to some of what I was describing. There is a national position on this, but we need to apply what this means for people in Leeds. So it's your point, what's the psychological language and tenure of this, so that it means something to people who may be on the receiving end of a phone. You know, many of you will have access to the NHS app. I personally have a view of it, which I perhaps won't share in this, but it's not straightforward, and it's another example of how difficult it is. But your point's the one that we're focused on. What does this mean for people who are either using our services or waiting to use our services? And then I think the other point about how do people receive support and care whilst they're waiting, I think that speaks to how we improve our conversation with our primary care colleagues and colleagues who are delivering health and social care. And I think about an event that was held probably only 2 or 3 weeks ago, where we had many of the operational leaders and senior leaders of Leeds in this building talking about how can we do things through a neighbourhood model. I don't think we're waiting to start from a neighbourhood model, actually. I think a lot of our colleagues are already working together, cheek by jowl, I would suggest, and are doing it naturally, but it could be better. Because where it could be better is to stop people getting caught up in bureaucracy or alternatively falling through the cracks of different pathways. There's more to do could have been the shorter answer on that one.
It's not actually just a follow-up question, but more that there was another question I did want to ask. This is more relating to maternity services. When we had a meeting before looking at the review, I asked about women-centred care, and it was sort of thrown back in that some of the complaints had involved men, also the partners, and that so therefore it seemed that the answer being women-centred care was obsolete, which the amount of rage was unbelievable at the time. But I've calmed down and I've come back to it now. And I just wondered if that is part of engagement now, is there is an understanding that it is patients' voices at the heart of those outcomes. And when we're looking at things like understanding those patients that often their complaints go amiss and don't get heard, and then are more likely to have severe or if not fatal outcomes, how we then are addressing that, acknowledging it and making it part of the primary treatment in those services. Thank you.
So in terms of women-centred care and partners becoming involved, we come from the family's perspective. So in complaints, I'll not get into too much detail, but I'm more than happy to have a conversation, another conversation if helpful, but we do what the family want. So if a woman, or if we ask permission of the patient, and if the partner is their advocate, then, irrespective of gender, then we will do what the woman wants, or the patient, whatever the patient wants. In terms of our complaints process, similar, we've reviewed this. I think the last time I came to this meeting, we talked about our review of complaints and that function. Where we want to get to is because it's feedback, complaints, is feedback, and it often indicates potentially a systematic failure, and we go see because we don't know what we don't know. The other thing that, where we want to get to is we want an action plan to address any themes from complaints. What may be unsurprising is one of the themes from complaints in every organisation I've worked is around communication, and it's about making that patient-centred, so whatever is right for that patient, which speaks to the text messaging, what one person would find as really good communication may not be for another one. So we try to do it like that. And I think in terms of the complaints review process, we've found areas where we can absolutely improve. The MMVP that I talked about later, we're really keen for maternity services to involve them in some of this improvement work. So our initial focus when we came into this improvement journey was, let's have a look at the complaints, let's have a look at the backlog, let's get them down, let's look at the themes, is there anything that we need to do with the service to change it? Is there anything that we need to, but we were absolutely clear that we needed to speak to the women and families that were involved in this service. What may be unsurprising is we've had a really significant increase in complaints into maternity services because of the national picture around, AMOS and the John Rockender report that Brendan alluded to earlier that you're all aware of, but also about the local press around our services. And we've got women from 15, 20 years ago, that gave birth 15, 20 years ago that are coming back to us and saying, I want you to look at my case again. We're saying no to, we're saying yes to everybody. So within the policy, within the NHS complaints policy, there is a time frame that you can complain. For women and children, we've said you can whatever, let's work with you. So absolutely in terms of review, because the next step will be about improving services, and we've already done some of that. So again, the work I've alluded to with the MMVP around signposting, around access, around things in different languages, that was as a response to some of it, response to some of the complaints. Does that answer your question?
Yeah, just only that I just think women-centred care is the answer. But yeah, I'm not there to give the outcome.
I don't disagree with you.
Thank you, Councillor Bromley. Okay, Councillor Lay next.
Thank you, and thanks for coming. I suppose first question, or the first thing to state really, is that we all understand the pressures you're under. You understand it yourself, 3.35. You say the central issue is you're delivering a service that's not funded by central government through the NHS. So my question around that is, bearing that in mind, what risks are there to patient safety and care quality if that additional funding and commissioning arrangements are not secured, and the central NHS disagree with you, and what contingency plans are in place? That's my first question. Can we answer that, and then I'll come back?
Shall I answer that one? I think that speaks to, if funding and support isn't secured, there needs to be a different conversation about how women are going to access specialist services, because that would mean longer waits, which means women's experience is going to deteriorate, as you described. So there is a conversation with commissioners about this is the consequence of that action. Now, what may need to happen, I can't predict that conversation. I'm not I deliver services, I don't commission them, but there is a point whereby we may need to reprioritise other services if this is the issue that needs focus and attention. But I think your point about risk is, as part of the conversations I described with specialist commissioners, we are constantly calling out these are the risks to the communities that we serve. But it's not just about the physical risk, it's also about the experience. And this is what it means to people's everyday life.
Thank you. I think as public servants, it's a difficult ask for yourselves to ask other public servants for more money. There is a element of political will required, and I think somewhere in the report it suggests that perhaps we help somehow, a scrutiny board, as local politicians, to promote the need for LTH to get the funding it needs to deliver this specialist service that it needs for West Yorkshire, not just the people of Leeds. The other thing I really wanted to ask is that COVID has been over at least 4 years now. Progress seems incredibly slow in removing the backlog. And I understand, obviously, people are coming onto the list as you're taking people off, and that hopefully nobody who went on the list in COVID is still on the list now. But progress is slow. Has there been any additional funding from central government to help lower or speed up the backlog? And secondly, you said there was 82,000 across all of the waiting lists. I've been on the scrutiny board on and off for 15 years. I've been an NHS nurse for 33 years, whatever it is. We consistently keep saying we need to move care from secondary care to primary care. It doesn't look like we're doing a very good job when the lists keep going up for secondary care. And I have one final question, if that's all right, or little... I'm a great believer in PIFU. My service that I help run delivers PIFU to our patients. Now, we only give them a week, but we're an urgent service, an emergency care service. But patient-initiated follow-up is really appreciated by patients. They get a name, or often they get a name or a service, and a telephone number, and it manages their anxieties about what happens next. Also, having had PIFU from the allergy and immunology service through LTH, I know how that made me feel. I haven't needed to use it, but they have been able to discharge me rather than saying, we'll see you in 6 months. It is the way forward, I think, because it does allow patients to take control of their own health care. We have become a little bit of a nanny state, and I'm a liberal with the big L and a small L, but we have become a bit of a nanny state in that we have to do everything for, rather than saying, people, you have a responsibility as well. PIFU is a good way of giving patients that responsibility.
So some of you, I can't comment on some of what you've said, but if I just, Mike's going to come in with some of the detail, but I think if we go back to the waiting list numbers, and certainly what we were describing as the elective recovery post-pandemic, it has been slow, but there are a number of factors to that, and I'm not giving you a political answer, but there is a level of increasing complexity that we hadn't seen pre-COVID. I think the way we operate our services, whilst we were caring for patients through COVID, I think there was one focus for everybody. Getting back on tracks took time, and I think the workforce that we're working with, the way we deliver healthcare post-COVID, there's a level of complexity to it that wasn't there pre-pandemic. I think some of what you've described around the narrative around how we move care closer to home, I agree. I'm 38 years in and I've heard it, but I do feel that it is moving differently this time. I think I'm not here to defend the government's 10-year plan, but I think the 10-year health plan has really taken some of that forward. And I know there is a concerted effort and certainly a narrative around how do health and social care services join up better than they are currently. So I wouldn't disagree with you about the length of time, but I do feel that there is a different impetus to it currently. And in a short answer to your question about whether we've had funding, there have been pots of money released, but there hasn't been consistent funding for how we improve on our surgical waiting lists and some of our outpatient waiting lists. You will see headlines around funding towards the end of the year, or if we've had sprints, for instance. So I can't sit here and say there hasn't been funding, there hasn't been consistent funding around this. Do you want to give?
Yeah, I think Brendan covered most of what I was going to talk about actually, but I think you're absolutely right. The impact of COVID, and we probably had in that first 6 months, we had a significant reduction in the amount of capacity that we had available to us for things other than COVID, and to try and then claw that back when, incrementally, our capacity hasn't significantly increased or improved in the 3, 4, 5 years since the worst of the pandemic. So you can imagine trying to claw back the capacity that you lost over 3 or 4 months when you're only adding on a small percentage each week to that is significant and challenging. What I would say that gives me some hope is we've seen a peak of the waiting list, I believe. We were at 95,000 or thereabouts. We are now mid-80s and we are coming down the other side of it. And just to give some assurance, the waiting list, when we talk about 82,000, obviously that's 82,000 individuals who are impacted by having to wait. Not all of them are having to wait, 60, 70, over a year. There's a number of our services that are delivering within the 18 weeks or significantly better than 52 weeks in terms of getting patients seen and treated, and hopefully people will have had some experience of those as well. And it isn't just patients waiting for treatment, it is people who are coming in waiting to have follow-up before an answer can be made about whether they should or shouldn't have treatment. So there's lots of different people within that waiting list, notwithstanding that every one of them's got a reason why they want to get to the answer as quickly as possible. So, we absolutely genuinely understand that, that constant drive to improve that situation has an impact at a very individual level for everybody. I think on the broader point around, where's the direction of the NHS and health in general, I think that, that population health approach to the way that we care for people within the city has to take us in a different direction to where we've been to date. The model that we've got probably, isn't the right model and probably isn't sustainable for the longer term if we carry on just doing what we're already doing. So looking at things like the neighbourhood health model, trying to get specialist care and specialist advice right at the front end of pathways, even before patients are referred in, so that we can have a conversation to say, would a patient benefit from having a specialist input or not, and get an answer back to a patient very quickly, means that it saves a huge amount of time for patients and their families, and it releases capacity for us to be able to do something different. And neighbourhood health, to my mind, isn't just about lifting up what we do in hospital and put it in a building that sits within a community. It's about changing the way that we deliver our services and get them much closer to the point where patients would be able to access them sooner. So hopefully that gives you a bit more of a flavour of the type of things that we're trying to do to improve things.
You are the Director of Transformation. You've got the big ideas, I suspect, so we wait with bated breath.
Thanks for that, Councillor Lay. I'll take that as a comment. So I've got one. Councillor Bromley's the last on my list. Does any other members want to speak? No. Okay. Councillor Bromley.
Thank you, Chair. I just not necessarily a question as such, but more just like a comment that I wanted to bring, if that's okay. So talking about that neighbourhood planning structure and then our concerns around waiting lists and the fact that we've asked for this to be brought to the board, is this something actually with a Revitalise New team that we would like to write nationally and sort of say, is there not just going to be pots of funding, but actually something that is sustainable and long term?
Well, thanks for that, Councillor Bromley, because that leads us nicely on to recommendations. So obviously there's a few recommendations in the paper which I think are fine and generic, and then the stuff I've thought that's extra, and we'll take Councillor Bromley's as a fourth. So the first one I wrote down was when Mike was speaking in the first section and he's saying waiting list for gynecology was coming down, and I wrote we should have a recommendation that says we'd like a written update in 6 months' time to see if it's still coming down, and if it's not, we need to bring them back. So that's my first suggestion. My second suggestion is to write to government about this commission of endometriosis services. I think we as a board should write and say we believe this is a service that is needed for Leeds and it needs proper sustained funding. I made a note that we've got a new health secretary, so we could write to her. Yeah, she's just down the road in Yorkshire, so I think we should do that. So I think that is something we should do. The third one I wrote down, and so Brendan at the beginning recognised the fact that he'd written to me in January and said endometriosis services waiting list was going to expect to go down in 12 weeks, and it's gone the other way. So I think we should have a working group on this. Previously in a working group we've had NHS England come, so when we had a dentistry working group, so I'm suggesting we have a working group where we invite NHS England on this point, and that might help if they haven't addressed this commissioning point by that point, but also maybe patient voice. I'll come to. Do you want to come on this item? Yeah.
I thought NHS England were being abolished, so who was going to take over? So who we're chatting to?
Yeah, fair question.
So not yet, but yes, the plan is that their form will change, but they're still in play, certainly for up to another year. Well, it's certainly less than a year now, but certainly up until next year. And just to the point about if there's a working group, it's about the endometriosis service for West Yorkshire, well, just about Leeds.
Yeah, I mean, we're more interested in Leeds, if I'm honest. I get that it's a service that covers West Yorkshire, and I think that's a relevant point in terms of funding, but I guess our priority, let's be really candid, we're most worried about Leeds, because that's our role. And then the fourth point was made, which I support, is made by Councillor Bromley about sustained funding for recovery of waiting lists in particular. Are members content with those recommendations? Is there anything else? Yes, Jonathan, come in.
You said patient voice. I think if we're going to have a working group, it's absolutely vital that the correct voluntary organisation is part of that as well, so we really get up-to-date information about the experience of people.
Yeah, thank you, Jonathan. And I was actually fully support that, and the correspondence I've had from both councillor colleagues and from the two groups that are here today has been quite challenging for me personally, because obviously I don't experience the female services, but it is important for us to shine a light on it, and I think it's something that we've got to hold our hands up and say there hasn't been enough focus on. So I'm very happy with that, Jonathan. So are members content with those recommendations? I'm seeing nods. Obviously, if you're online, you can't see the nods, but there's full support for those 4 additional recommendations. So with that, I will thank NHS colleagues for coming. I appreciate your coming, being really honest and recognising the challenges. Look forward to continuing to working with you to improve the services, and I'm sure you'll be back soon. We're going to just have a short break, so we'll be back at 3 o'clock according to the clock on the back wall, so that gives you about 8 minutes. Thank you very much. Everyone, welcome back to the meeting. Just can I bring everyone's conversations back to the meeting? So, welcome back. Thank you for joining us again. So we're going to talk about item 8 next, which is Heat in the City report. I start with, we've got 2 new people around the table, so I'll start by asking you to introduce yourselves. Thank you.
Hi, my name is Dawn Bailey. I'm Chief Officer and Consultant in Public Health.
Hello everyone, I'm Hannah Sauerberts, Head of Public Health for Health Protection at Leeds City Council.
Thank you very much. Before we start, Councillor Flint, do you want to make any opening remarks?
Yeah, I've just got a few remarks. Thanks, Chair. So this is the report 12 months on from the Heat of the City Director of Public Health report, which I guess after the last few months we've had, was obviously a very important report, and it's good that we're discussing it 12 months on. The report highlights the unequal impact of heat on health within many communities in our city, and the recommendations within the report are a call to action for all system partners to consider how heat and heat mitigation is considered within their own policies, planning and public-facing messaging. We have a collective responsibility as system partners to mitigate the impacts of heat on health and strengthen community heat resilience in the face of rising temperatures. I'm pleased to report that we've made strong progress over the past year. This includes the introduction of new public-facing initiatives, as well as the development of a new research opportunity with academic partners. The report has acted as a catalyst for discussion and enhanced cross-council and sector partnerships, as well as national recognition of Leeds as an exemplar authority for our work on heat and health. In particular, the report highlights several key areas of success. The development of our Cool Spaces scheme, which operates within 40 council venues now throughout the city, which I was delighted to launch at the Compton Centre on the 1st of June. The first Cool Spaces scheme in Yorkshire and Humber, and I remember the penguin sort of overheating in the outfit at the time. The report also highlights promoting and embedding heat health advice and resources within our frontline workforce, aligned to the UK Health Security Agency's Adverse Weather and Health Plan. Strengthening our local research, evidence and surveillance in relation to heat distribution across the city and people's lived experience of increasing temperatures. Integrating heat and health considerations into our Commission services and local policies. And raising public awareness of vector-borne threats, such as ticks and Lyme disease. The recent weather events, including multiple heat waves and thunderstorm warnings in May and June, do serve as a timely reminder that extreme weather events are becoming more frequent and more unpredictable in Leeds and indeed across the country. It is our most vulnerable populations, babies and young children, pregnant mothers, older people, people with long-term health conditions, and people living in our most deprived neighbourhoods who face the greatest risk and challenges as a result of these events. Heat resilience work has remained firmly focused on improving health outcomes, reducing inequalities and building long-term resilience as our climate changes. The report demonstrates that a clear vision and strong partnership working can translate into real, measurable progress for our residents. However, as temperatures continue to rise, this remains a long-term challenge, and our sustained focus will be on protecting the health of our residents. I think I'll hand over to Hannah now.
Thanks, Councillor Flint. So yes, good afternoon, everyone. Thank you for having us back to this board. It's 12 months ago that we were last here presenting on the 2025 DPH Heat in the City report. So as Councillor Flint has introduced, we're here to just update you on some of those key areas of progress and development over the last 12 months. Next slide, please. Thank you. So obviously you've all had the report. This is just a brief summary of some of the key findings within the report, some of the key areas that we've been working on. So one of the key areas of data that's presented in the report is that Leeds is getting warmer year on year. So we use the Met Office heat barcode to demonstrate this. So this is an annual average temperature recording, which has been happening since 1890. The darker the blue, the colder the year, the darker the red, the hotter the year. And this really clearly demonstrates in a very visual way is that over the last 130 years, our average annual temperatures within the region have increased. And actually the Met Office have now supplemented this with the National Heat Map, which provides a progressive illustrative average temperature recordings over the decades. So you'll be able to see on the image that it's flicking through different time periods. And actually what's of interest is that if we look at the 2016 to 2025 average readings compared to 1961 to 1990, actually Leeds has become 1.3 degrees Celsius hotter over that time. So since the report was launched last year, 2022, which at the time was the hottest year on record, has now been superseded by 2025, which is now officially the warmest year on record nationally since 1884. We've also had new temperature records this year. So spring 2026 is the warmest year on record for England. And as Councillor Flint has already said, within the last 2 months, we have had 2 heat waves, which again have set records in terms of the hottest May day on record on the 26th of May, and also the warmest average mean temperature in June for England, which this year, which is now a new national record. So again, just next slide, please, Angela. So again, just drawing your attention to another key data set that we presented within the report is the impact on mortality. So historically, when we look at weather-related excess deaths, often, or to this point, we've always seen our highest number of daily deaths happen on our coldest days. But what we're starting to see now is that actually during years where we have heat waves, we're seeing the highest number of daily deaths actually happening on the hottest day of the years. So this is a real shift in that historical excess deaths data. And I think we talked at the last board about really needing to have that focus on summer planning like we do on winter planning when we look at sort of service pressures, seasonal pressures. As we've already said, we have even this year had those heat waves in May and June. We're starting to see some of the national data coming through now in terms of impact of the May heat wave. So nationally, it's estimated that about 550 people have died with of heat-related causes due to the May heat wave. Obviously, that's national figures rather than Leeds figures. And we know that our modelling by people like the Met Office, organisations like the Met Office, sorry, indicates that extreme heat events will continue to happen more frequently. As Councillor Flint has already said, you know, there's lots to celebrate in terms of what we have achieved so far as a system, you know, working with partners. All DPH reports are a call to action around priority areas. Sorry, Angela. All DPH reports are a call to action around priority areas for the whole system. So although public health and the health protection team have held the ring in terms of many of the discussions and some of the key programmes of work, we have absolutely worked with all system partners and encouraged them to consider how they will respond to the findings within the report and the recommendations that we presented. But I think it's fair to say that the report has provided a really powerful and timely platform for discussion and engagement around the impacts of heat with multiple partners, including internally within our own organisation. We've worked with different colleagues around the council that we well, personally, I've never worked with before within public health, but also local system partners, national and international partners in terms of some of the academic opportunities. But in brief, and again, this is in the report, we have launched the Call Spaces scheme, which is a brilliant achievement. We know to date we've had, it's been recorded that 666 people have used our Call Spaces in Leeds since we launched on the 1st of June, and that's specifically for heat shelter. So that's not for the wider services within those settings. We've had over 4,500 visits to the Call Spaces website. So I think it really demonstrates the need for Call Spaces to be a permanent offer within the city, and we're already exploring options for next year around how we expand that offer to be able to include third sector and community settings to mirror that really to mirror our welcome spaces approach within the city. So the report also looks at emerging health threats, vector-borne diseases. As Councillor Flint has already talked about, we have launched our tick awareness approach this year in Leeds. So you may have seen signs and banners across all of our Leeds parks and estates, really trying to raise awareness amongst the public of ticks and how to avoid tick bites, but also how to seek support if you have been bitten by a tick. We have also targeted all of our pet stores, garden centres, dog walkers, but also working with schools and early years settings as well, especially in that lead up to the summer holidays as well, where we know there'll be lots more families enjoying outdoor space. Research and innovation, we have had the opportunity to work with so many different academic institutions around heat and heat resilience. So we are at the same time working with University of Leeds, also Leeds Beckett University, as well as the University of Sydney, to on lots of different research studies. So within the report, you will see that we are part of a national study called SHIELD, which is looking at heat resilience among care services. So really how we support our care services to keep residents and keep service users safe, as well as staff during heat periods of heat, but also what we can learn from other hot countries as well in terms of heat resilience. We have also worked with colleagues across the council to really introduce that question about how are we considering heat and overheating within our local policies and our community facing services. And so we have worked with colleagues to ensure that it's included in lots of different community offers. So things like the Warm Homes Local Grant Scheme now includes support around heat. We are working with the Green Doctor as part of an existing Public Health Commission service, who historically have offered support with people around how to keep their homes cool. We're now flipping that during summer to working with people around how to keep your, sorry, the other way around, how to keep your home hot. We're now working with people around how to keep your home cool during the summer periods. We're launching a scheme to support care homes in terms of overheating and thermal efficiency. And also heat is now included within the the Leeds Health Impact Assessment Planning Tool template, which is aimed at developers. I think Leeds, we've always done a lot as a city in terms of our health protection work around weather health, but Leeds has really been recognised as a result of this report around being an exemplar for weather health. So we are working with the UK Health Security Agency to really promote and champion how local authorities can turn national policy around weather health and around heat health into local action. And they have really embraced working with us to launch some of their summer resources and promote the Leeds approach to heat health on a national platform as well. And then finally, community engagement. We obviously the most important element of this is around engaging with communities and ensuring that our communities are resilient and engaged around heat health. So we've been working with organisations such as Climate Action Leeds. We to look at how we can work with their volunteers, how we can engage with communities around heat health. How do we learn, continue to learn from people's real lived experiences of living through heat waves, and how do we put that into action in terms of policies and our campaigns? Yeah, last slide. Thank you, Angela. So in terms of next steps, just to quote Mike Kendon, who is the Met Office lead author for the latest edition of the State of the UK Climate Report, what we used to think of as extreme, we increasingly consider as normal. And I think that is something that we're carrying through with a lot of our work, that we need to be prepared as a city, as a country, for increasing temperatures. Heat resilience should be a priority for all system partners. And as a health and care system, we should be able to, and we need to provide assurance around our collective robust heat mitigation planning, which mirrors our approach to winter planning. As I've said, we need to continue to engage with communities around what more we can do collectively around community engagement. And our focus shouldn't just be around reactive work with communities. We need to do more of the proactive work as well. And finally, we need to find more sustainable. We need to continue to work around sustainable approaches to policy and city development around heat and heat resilience. So we've already talked about it at the meeting today, about opportunities on the horizons in terms of neighbourhood health, community pride, our locality approaches, things like Heart of Holbeck, the South Bank development. We want to really work with colleagues to look at how heat and heat mitigation is being considered as part of those big infrastructure developments, so that we're taking every opportunity to think about heat and heat resilience within new opportunities within the city. So thank you.
Thank you very much for that, Hannah. Really helpful, and I'm glad that we're taking the heat seriously. Really interesting chart in terms of daily deaths. It's clearly a big impact on a lot of people. I'm going to move to questions. I'm going to start with Councillor Bromley.
Thank you, and hello again for like the fifth time, maybe, I don't know. And as you can imagine, I might have a few questions, and thank you so much for following up on so much outside of this as well. So in terms of a couple of the things that we did in introductions, I just wondered if you did have any further conversations on the schools. I know the organisation Let's Go Zero went in and they do like free evaluations for their climate action plan within schools, and that part of that question is how is the school working with in heat during sort of academic term for young people. And I wondered if then we had any involvement with conversation around uniform and stuff like that we did touch on at the last report. My second question is sort of more around trees, and then so not just necessarily heat within buildings, but also out and about, so along high streets. I know that we have been really cautious here in Leeds in terms of planting trees along high streets, and that comes back to utility companies. But is there actually more engagement that we can do with highways, so that our high streets, so that people are maybe accessing their local pharmacy, is actually a shaded area during really hot times? And then my third question is around the cool spaces. Really good that we got that into the website and then out there for people, but a little bit limited with the 40 building access. And I know that there was third sector organisations that did want to get their name on the map, but they couldn't. And also on a local level, I then had to engage with organisations to see if they would open up their space, because very conveniently, Earth managed to give us an example of a heat wave just before coming today. But yeah, a massive support network though for people in communities, and example didn't it that is really needed, and how useful that's going to be, and continue need as well. Churches seems to be a really obvious venue, so I just wondered if that could almost just be like every church that's a heat space is just like automatically converted to a cool space. And then the other part of it, which you did still on the cool spaces, you did touch on some potential funding coming in to be allocated, but I just wondered how much that is. And if it's that organisations could allocate that to then making their organisation more cool with things like aircon, or whether it's simply just to open up the building.
Hi. Well, thank you to Councillor Bromley for all your, as you say, all your support during over the last year. I know you've come to us with lots of ideas and introductions, so thank you for that. I know that we had a conversation at the time in terms of support for schools around sustainability and heat resilience. I know that there was a fund that schools could apply to at the time, which it was a West Yorkshire fund that I think had just finished. But I did check in with colleagues from our Healthy Places team and they were aware and had promoted that fund to school. So I think it's an area that we'll continue to work with Climate Action Leeds around, who I know were one of the organisations that were supporting that. But climate resilience is definitely something that schools within Leeds are encouraged to think about and engage with through organisations like Climate Action Leeds and other organisations, and we're fully supportive with our children and families team around that. In terms of uniform, I think that was your second question, just around schools and uniform. I know we work with colleagues from the schools health and safety team, as well as the children's directorate within the council, to promote any Department for Education guidance that comes out around heat and heat resilience. And I know there's certainly been obviously quite a lot recently with the recent heat waves, and actually the UK Health Security Agency and DFE did update the school policy on uniforms. So we've done as much as we can to try and promote that through early years settings and through our schools platform as well. And I know that it went directly to head teachers as well. So trees, I'm very interested in trees also. I think we've got some we're very lucky as a city in that we have some amazing academics that are also very interested in trees, and you know, we can really harness that academic expertise within the city and should be doing it, and I can assure you that we are. I think, as you say, it's not just around planting trees, it's about planting the right type of trees in the right positions, and I think we are very engaged through our Healthy Placemaking group within public health with planning colleagues, with colleagues from city development to try and work with them around that. As I said in my presentation, you know, we really want to engage with all of the existing work that's going on around city development to use that existing opportunity to make the right decisions that will help us around heat mitigation. But yeah, there are some choices that we can make that would be better in terms of greening for heat mitigation that we need to look at. In terms of cool spaces, yes, we knew this year was our pilot. We didn't have an allocated budget, which is why we worked with our existing civic spaces. I think it's fair to say that we've already really proved the need for cool spaces, and so we're working with colleagues who oversee the Welcome Spaces scheme to look at whether we can extend the Welcome Spaces scheme to run all year round. Currently it runs over winter, so the funding would be for people that run Welcome Spaces. I'm not aware of the budget at the moment for Welcome Spaces. It is very early days in terms of conversations, but I know there is a commitment there from colleagues to explore, and they're very supportive. In fact, we have worked in partnership with those colleagues to develop cool spaces. So, but I can certainly keep you up to date with developments around that. I'm sorry, I don't know if I've captured all of your questions.
I think you did. That was fantastic.
Okay.
Thank you.
Thanks.
Thanks, Hannah. Okay, Councillor McCluskey.
Just to follow on from the cool places, I mean, I could see this year with a pilot using council buildings. Some wards don't have that facility or have any council buildings, and so building on the current warm places bits, Councillor Bromley raised, how do you assess? Because I can get a warm place is easier to assess because it's got a central heating system. It's got place to be. How do you assess whether it's valid as a cool place? Because keeping cool is a bit more difficult in our buildings than it would be in say keeping warm.
So in terms of our existing civic buildings, I think one of the benefits of working with our team that already oversees libraries, community hubs, was that they were able to have a really honest conversation with existing centre managers to say, do you feel that you will be able to keep your building below 21 degrees Celsius, which really is where we need to be at in terms of indoor air temperature on very hot days. And there were simply some older buildings that said we don't feel that we can do that, so they weren't included. So some of the older libraries were not included, for example, as a core space. However, everyone else, so everyone on the list, so all of the leisure centres that are on the list, all of the neighbourhood networks, community hubs and libraries all came back to say we feel confident that we can keep our buildings below that temperature. We've provided them with thermometers and they do daily record checking of those temperatures. And in situations where there are, the buildings are getting hotter, there has been some investment in fans and they are looking at some air cooling units as well. But we did have that conversation before the scheme started, just an open, transparent conversation about centres' abilities to they know their buildings best and they know how hot they get on a hot day. So, yeah. But going forwards, these are the conversations we're going to have with a wider number of people. And there is an element of people having a champion for weather health within their organisation, within their building, that will keep an eye on temperatures as well, because we need to be mindful that we need to keep, if we're advertising it as a cool space, it does actually need to be cool.
Thank you. Okay, Jonathan, if anyone else wants to ask a question, do indicate, please.
Thank you. I was wondering if you had any particularly targeted support for people and advice for people who are living in high-rise accommodation.
The report absolutely recognises the unequal impact of different types of accommodation on people's heat risk, and living in some high rises does amplify that risk. We're still engaged with some of the tenants' organisations that represent the high rises, and in fact we're in talks with colleagues from housing at the moment around trying to engage with residents living in different types of housing to be able to build our case and build our evidence base for Leeds' urban heat island. So we know that there are some areas within the city that are hotter than others, and we can demonstrate that through data and thermal data, but we also want to be able to demonstrate that through people's lived experiences as well. So I'm currently in conversations with colleagues from housing and from Climate Action Leeds to engage with people living in different types of accommodation, including high-rise flats, to try and engage with people around their experiences of living in heat. In terms of recommendations for people living in I guess more challenging accommodation, we do have an offer through Care and Repair, through the Green Doctor service, where people that meet certain criteria can actually get free advice, and in some cases may be eligible for different equipment, kind of blinds to go onto windows, cooling mats, fans. So I'm happy to share the details, referral details for that service if it would be of use.
Yeah, Victoria.
Yeah, thank you, Hannah, and thanks for the question, Jonathan. I guess just to add to that, in the report itself, there was a particular focus on people in some high-rise accommodation being more at risk, depending on which ones and depending which way their aspect was. And I guess it really exemplifies the fact that the actions that have so far happened around cool spaces and around kind of mitigating some of the risks in very practical terms in those homes are really important. But this is a longer term issue that obviously, you know, for people to be able to leave their homes in hot weather and go seek a cool space, and also to try to do what they can to stop the heat coming in is a practical thing for now. But we really need to get into this issue of planning for the long term in terms of our housing strategy, and obviously that takes years and decades to do. But I think it's a good example of how there's some short-term actions, but that's really one of the things that we had feedback last year. Was around the fact that the report had kind of made the case for why heat was a public health issue, and people hadn't necessarily felt that way before or thought about it. So I think there was a case to be won in sort of presenting the data and bringing people on board, which was quite easy to do in the middle of a very hot summer, easier than it would have been otherwise. And obviously we've had a lot of hot weather already this year, so even though this is last year's report, it feels like this is going to be a very long-term report that we'll just stick with, and it'll run alongside every single other report we produce in the future. So I think the high-rise example is one of those that really shows how we have to be in this for the long term. We have to rethink our infrastructure. We've got to rethink the way we design and build our housing for the future generations. That this is not a short term. Obviously, everybody in this room, I'm sure, knows we can do short-term things, and we have to do short-term things, but obviously this is leading into more challenging conversations around what we need to do in the medium and long term, and part of that is around looking at our high-rise stock and thinking about what's sustainable and how is it sustainable for the future. Thanks, Chair.
Thank you. Great. Okay, Councillor Bromley, did you want to come back in?
Sorry. Just wanted to come back on the tick conversation. With it just being like something like we was talking about women's health, that actually the sort of research around it is new. And so emerging understanding, and so especially because ticks, it can be absolutely debilitating and life-threatening, can't it? So in terms of recognition early and seeking help is probably very crucial. So when the engagement as well and the information, is that going out to like all community centres and local libraries, and or is it mainly around schools so far and GPs?
We have a multi-pronged approach. So we have targeted places where we know ticks will be. So in places where there's longer grass and, so our parks, countryside estates have all been given correct posters, as we call them, and banners. We also, through our Public Health Resource Centre, have printed materials that have been promoted to all of our third sector partners. So any organisation that is signed up to the Public Health Resource Centre can access those tick posters and that tick information. And we have hard copies there, or we can send people electronic versions if they would wish to have that. You're right in that, we know that as our temperatures increase within the city, it provides a longer more optimum and longer breeding ground time period for ticks. Not all ticks carry Lyme disease, but we know some do. Obviously we're encouraging people to take measures to prevent tick bites through what they're wearing, but also, using tick and insect spray. But we are also encouraging people, if they do find a tick on them, to actually send it in. You can send it to the National Surveillance library. And you don't get a result back from that, but it just helps us and helps the UK Security Agency build our mapping around ticks and what ticks are carrying. So on all of the posters and all of the banners within the parks, there's 2 QR codes. One is around signs and symptoms and how to seek support, and the other is details on how to submit ticks to the National Surveillance Scheme.
Thank you very much. I can't see anyone else indicating, so let's move on to recommendations. So I'm just thinking on my feet a bit here. So on item B, I suggest we add something along the lines of recognising there is more to do in this space. So I think you've started. I think obviously there is more to do, and I think the point that Victoria made very well was this is a long-term project. So I think that'd be important. And then I was thinking, given the comments made, it feels like there's strong support for cool spaces growing. And if members are content with that, I think we should put in a note that says we support the expansion of the cool space provision, whether that's through, we don't need to be specific about whether it's through churches or other community organisations, but we'd support that. So are members happy with those recommendations? Yes, happy. So seeing nods around the room. Thank you very much, everyone. Thanks very much for coming. It's really important that we start recognising heat and the challenges it brings. So we appreciate your time today. Okay, moving on to item 10, the work schedule. Hopefully you've had time to read it. Are there any comments, questions that members want to raise on the work schedule? I can't see anyone indicating, so I think we note it and move on. And then finally, date of the next meeting, which I haven't actually checked, is the 8th of September at 1:30 with a pre-meeting for members at 1 o'clock in here. Thanks everyone so much for coming today. Really appreciate your input. I think we've had good conversations and we've got some actions coming out of it, which I think is also important. So thanks for your time and see you after the summer.